Marco is here, so... Dear friends, it is a pleasure for us, Dr. Marín and myself, to moderate this last session on antithrombotic therapy in acute coronary syndrome. We are very lucky for being here with such outstanding speaker, Dr. Angiolillo, Dr. Kastrati, and Dr. Valgimigli. The three are very well known and don't need any further presentation. So let us start and enjoy it with their talks. Besides, we decided to have the full discussion at the end. Dr. Angiolillo, Dominick, can you tell us when and which antiagregant we choose to start? And also, when and how to do the switch?
Thank you, Mr. Chairman, ladies and gentlemen. I would like to start off with thanking the meeting organizers again for this very kind invite. I'd also like to thank all the sponsors, because obviously without your generous support, this meeting would not be possible. And I'd like to thank all of you for staying here. This is the last session. It's a beautiful day outside here in Malaga. So thanks to all. So I have two questions to answer. So my talk actually has two components, when and which drug to start, and when and how to do the switch. And I'll keep my talk to 20, max 25 minutes, because I know we are late. These are my disclosures. And I will start off with a very simple case. We have a 67-year-old white male who comes to the ER with worsening dyspnea together with chest pain for the past couple of hours. And he's been feeling sick for the past couple of weeks. He has an EKG with some ST depression in the infralateral leads. Physical exam, nothing really that remarkable except for some bibasal rails, and he has a soft gallop. And his symptoms and his EKG changes completely resolved with sublingual nitroglycerin. He has a long history of diabetes, series of cardiovascular risk factors. His home medications, he was on insulin, lisinopril, metoprolol, simvastatin. He was taking aspirin but decided to stop. And his labs, as you can see, show a positive cardiac enzyme. And so clearly we coined this patient as a non-STEMI with a high GRACE score. So the patient is treated with aspirin, and he started on a heparin drip. So we're all in agreement with this. Cardiologist is consulted. The patient goes to the CCU within 2 hours. Patient's fine. He's completely asymptomatic. And the plan, at least in our hospital, that patient is going to go to the cath lab the same day. There's no reason to wait. The question is, when we're speaking about which treatment to start with, does this patient need more potent antiplatelet protection, including a P2Y12 receptor inhibitor? Now, the issues with pre-treatment with a P2Y12 receptor inhibitor has been a huge debate for many years. And I say that the major drawback is what you see over here, is that many patients going to the cath lab do not have coronary disease. Many patients going to the cath lab do not get PCI. And we have still 10 to 15% of patients who may require bypass surgery, and therefore if the patient is pretreated, that exposes the patient to increased risk of bleeding complications, prolonging hospitalization, and therefore cost. And we live in a world of being very, very cost sensitive. And so the question is, what do we do? And these are the most recent guidelines from the European Society of Cardiology, and make a dramatical change compared to what you've been used to for so many years, where the guidelines used to say, start as soon as possible with a P2Y12 inhibitor. And you can see here that the only clear recommendation was for prasugrel, where it is not recommended to pretreat. In regards to clopidogrel and to ticagrelor, the guidelines say no recommendations, either in favor or against. Kind of strange, right? But these are your guidelines. So the question is, why these changes, these dramatic changes, and most importantly for you, what do you do in your clinical practice? So let's try to understand what's happening in U.S. practice. Here you see some data from real-world registries showing that really only 30% of patients in the United States are actually pre-treated. And you can see over time with the introduction of the newer agents in the non-STEMI and STEMI settings, this is going down and down and down. Reason because we have agents that kick in pretty quickly. but also because the time of going to the cath lab has dramatically changed over the past 15 years. We no longer live in the era of the CURE trial where the median time to go to the cath lab was around 10 days. Typically, patients go to the cath lab very, very soon. So let's look into some of the data and let's look into why we've had these changes in practice patterns and also in guidelines. It's non-STEMI. Here we have the CURE trial, very important trial, and we know that starting sooner was associated with a 33% relative risk reduction in ischemic events within the first 24 hours. But this is when you add to the endpoint severe ischemia to the harder endpoints. But there are some considerations that need to be made. Well, first of all, CURE was a trial of a conservative management. In fact, only 50-70% of patients didn't get a heart cath. PCI was performed on only 21% of patients. The median time to the cath lab was 10 days. In one word, it's an very important but outdated trial. What about CREDO? Here you see the analysis of pretreatment versus no pretreatment. What most people forget is that the trial was negative. This is the main reason that the FDA, at the time of the design of the Triton trial, denied pretreatment as a strategy within the trial design. Considerations here. This was really not a trial of pretreatment because in the study, most patients had their cath done, they knew the diagnosis, and they knew they were going to get a PCI. So then they got randomized. That's not true pretreatment. You're not blinded to coronary anatomy. Patients were loaded with a 300 milligram loading dose, and again, sort of an outdated study. But we have some interesting analysis, similar to the CURE trial, that with the number of hours of pretreatment, you're seeing an exponential benefit. So it's not that there's no benefit to pretreatment. It depends a lot on timing as well as clinical presentation. But we heard also from Dr. Andreotti that for the stable guidelines, it's a class 3, do not pretreat. This is based on the Prague 8 study. We'll have also the Armida 5 study, again, showing no efficacy but potential for harm. And so the question is, this is ineffective, but we really never had a dedicated trial in a modern era with modern therapies in patients undergoing an invasive strategy until the COAST trial. This used prasugrel, 30 milligram loading dose of pretreatment versus in-lab treatment. As you can see, no ischemic benefit whatsoever, but increased risk of bleeding. And in any shape or form you dice the data, it was the same. So the question is, definitely with tynopyridines, lack or minimal ischemic benefit, but increased bleeding. So the question is this a class effect? Is this related to tynopyridines? What about ticagrelor? Well, the guidelines do elucidate some of this information. Again, a class 3 for prasugrel, class 3 for routine use of 2B3 inhibitors. And with ticagrelor, I think that the guidelines were very, very objective. They say, we don't know. Because the trial that we do have, which is the Plato trial, everybody was pretreatment. So we cannot say that pretreating versus in-lab treatment is better. We just don't know. And that's what the guidelines say. In fact, they're silent to this extent. However, there's an issue, well, many patients are coming to the cath lab. There's a knowledge gap. And there were some critiques saying, well, can we give the drug in the cath lab, for example, with ticagrelor? And this knowledge gap was filled by the ad hoc PCI trial, where, for example, very useful in US practice, where patients are not pretreated, can you do better than clopidogrel? Now, this is a very, very intuitive study, but it had not been demonstrated. And clearly you can see that why do you need to wait? You can give a potent drug. You have immediate potent platelet inhibition, definitely a lot faster and a lot stronger than clopidogrel. And what I say, if this is not strong enough, we have newer therapies such as intravenous therapies like Cangalor. I explain it as an on-off switch, immediate effects, and immediate offset of action. Recently approved both in the United States and in Europe based on the Champion Phoenix trial, as you can see here, all patients who were not pretreated with a tynopyridine and with a benefit compared with clopidogrel. However, I do realize that my reality is not your reality, and the reality of clinical trials is not the reality of real-world clinical practice. This is analysis from the iShot registry, which comes from Italy. In my opinion, it resembles a lot of what's happening in Spain, and there are clearly differences between cath lab, hospitals that do and do not have cath labs. And you can see that hospitals that do have a cath lab, the median time to the cath lab is around 29 hours, and those who do not, almost 60 hours. And in this population, around 80% of patients were pretreated. Maybe this really reflects your reality. And so there's not a right or wrong answer. In fact, the guidelines do give, the European guidelines give leeway. Evaluate what's happening in your clinical practice. Now, in my practice, again, most of our patients are not pretreated because they go to the cath lab pretty early, and just like at Mayo Clinic, as Dr. Bell was saying, we come in on weekends and we do our non-STEMIs. My opinion, in 2016, a patient should not wait 2-3 days to go to the cath lab. But that a lot depends on who's on call. Now, if you get a referral patient from another hospital, obviously they may be pretreated. And if you have somebody who's on call who's living out at the beach, Jacksonville's a beautiful area. Some of my colleagues live at the beach, don't want to come downtown Jacksonville to do a heart cath. These patients will probably be pretreated. However, the take-home message, you need to do what's right for you, and particularly if the times to getting to the cath lab are beyond definitely the 24 hours, your patient should definitely be treated because aspirin and heparin alone is definitely not enough. Now, what about STEMI? Well, with STEMI, there's even less data because there are less trials. This is a snapshot of the studies that have been done. A few studies with clopidogrel, all underpowered. I think the best study is definitely the Atlantic study, which I'm going to show you right here. You can see here the Atlantic trial, very interesting study, where, however, pretreatment with ticagrelor 31 minutes prior, that was the mean difference between those treated in the lab and those pretreated, no impact on the primary endpoint. There was a signal in differences in stent thrombosis. I always say interpret with caution, study not powered for stent thrombosis, but no differences in bleeding. So the take-home message is, okay, if you want to pretreat, it's fine, but you're really not going to see much of a benefit. And my interpretation of the data, you don't see a difference in ischemic events, you don't see a difference in bleeding, but this is simply due to the fact that the drug is not working yet. There's a difference of 31 minutes. What happens in STEMIs is what you see over here. There's very poor absorption. Now this is actually a true figure. This relates to clopidogrel, 200-300 milligram pills, but the same happens for all medications. This is particularly in STEMI for a variety of reasons. And you can go up higher and higher with the dose. This is a randomized study that we did going up to 360 milligram of ticagrelor in the cath lab. No differences whatsoever. You need to wait at least 4 to 6 hours, and this underscores the importance of intravenous therapies in these patients. So in STEMI, to pretreat or not pretreat, well, I personally don't see a difference with 30 minutes of pretreatment, but this is my practice. We have a huge problem, at least in my region, where we have a lot of false activations because STEMIs are not always activated by cardiologists. So why pre-treat in a patient who may not be having NMI? But in your system, where the system actually works, you have better cardiologists maybe, or better infrastructure for your STEMI network, I don't see any harm as long as this does not interfere with getting the patient to the cath lab. I'll now switch to my next topic, which is about switching. And switching has been a relevant topic over the past years for the very simple fact that now we have 3 oral P2Y12 inhibitors, and so we have choices. And when we have choices, we can switch between different drugs. This is a snapshot of what's happening in the United States, showing that switching between a first generation to a second generation tenopyridine or vice versa happens around 13% of patients. This is just in hospital. If you take numbers outside of the hospital, I would imagine that that number is even higher. The registry data in Europe showing similar numbers, which are actually even higher. So switching is a problem. And when we're thinking about switching, for years, we've always had 2 main concerns. Is there a problem with overdosing, and is there a problem with drug interactions? So here I've outlined the several conundrums with regards to drug interactions, or better off switching conundrums, for example, switching from clopidogrel to a new agent, so an upgrade, switching between the 2 new agents, and a downgrade, going from a new agent back to clopidogrel. Okay, these are the switching in all the different salsas that I know. And then we have a future one, which is switching from Canglor to the new therapies. But I won't speak too much about that. Let's speak about the upgrade, going from clopidogrel to a new therapy. Well, we know that many patients are still pretreated with clopidogrel. That's happening a lot still in Spain. And the question is, well, when the patient gets to the cath lab, can you upgrade, go to a new therapy? Well, with ticagrelor, the answer is very simple. The answer is yes, because half the patients in the trial were pretreated. It's safe, it works. Just go big, 180 milligram, don't worry. The question is with prasugrel is because in the trial, in the Triton trial, these patients were excluded. So there's a need for a dedicated study. And so this is what led our group to start a series of studies called SWAP. Pharmacodynamic, proof of concept. We will never have a clinical trial. And this is SWAP 1, switching from clopidogrel to prasugrel. And clearly what you see here is that when you switch immediately to a 60 milligram loading dose, you have immediate platelet inhibition. And if you go to a maintenance dose, it takes a full week. So the take-home message for you is When you want to switch, it all depends how quick you want to achieve your immediate platelet inhibition. Now, if you're switching to prasugrel or to ticagrelor, most likely you're in an acute setting. Just give the loading dose. It doesn't matter when the patient received the last dose of clopidogrel. If the patient received it 30 minutes ago with 600 milligram, it's fine, just load. And let me explain to you why. This is a Mr. Platelet with the P2Y12 receptors. We give a loading dose of a newer agent, for example, prasugrel, we block most of the receptors. Mr. Platelet again, exposed to clopidogrel, you block less receptors. Now, if you give a loading dose of a more potent agent, what's going to happen? You're just going to block the remaining receptors. You cannot block more receptors than those on the surface, and you're not going to have a drug interaction. And the excess, for example, in prasugrel, in this case, is just rapidly eliminated, and if it's ticagrelor, it's just going to attach to a receptor once it becomes available. How about switching between the new therapies? Well, this doesn't happen too often, but it does happen. For example, you may want to switch from ticagrelor to prasugrel because of dyspnea or need for once daily medication, or switch from prasugrel to ticagrelor because you didn't realize the patient had a stroke. That happens a lot of times. We come in, we do STEMIs, and then you ask the following day, hey, by the way, did you have a stroke? And this patient says, yes, I think so. Somebody told me I had a mini stroke, so you just got to stop the drug. So this led to the SWAP-2 study, and this was a very interesting study. So this introduces the concept of drug interactions where you need to be careful. Here we clearly show that when you switch from ticagrelor to prasugrel, there's a very potent drug interaction where nearly half the patients within the first 24, 48 hours had high platelet reactivity. So imagine this is a patient with a recently implanted stent where you're observing this, and this is with a maintenance dose. Now you can mitigate this giving a loading dose, but it's still there. So always a lot of caution. Always give a loading dose, and again, just be aware of this potential for a drug interaction. I can explain the mechanism later. Now, what happens the other way around from prasugrel to ticagrelor? This was just reported last week. We did not see this, and this is because of different biology of the two drugs. When switching from prasugrel to ticagrelor, it didn't matter if you were giving a loading dose or a maintenance dose. You have an additive effect, not overdosing, and you see a smooth transition. So very important message from a clinical standpoint. Now, the next big question is, what about going the other way around, from the new agent back to clopidogrel? Now, unfortunately, with a generic clopidogrel, nobody wanted us to fund a study for this, and so we try to find ways to come up with a clever idea to do this. And, you know, the biggest issue that we have in the United States is cost. You know, clopidogrel costs only $4 a month, and somebody's going to have to pay for the other agents. And even if you have good health insurance, people don't want to do the copay. They want to go with what's cheap. So with prasugrel, if you're on prasugrel going to clopidogrel, there's not too much big of an issue because you can switch and you still have protection for 7 to 10 days with prasugrel. We learned this from the recovery study on how long prasugrel works. The biggest issue is with ticagrelor because you have a very rapid offset of action. So essentially what happens if you're giving a maintenance dose and it takes 7 days to achieve the full antiplatelet effects, you're going to be here with a gap. And that's not a good gap to have if you have a patient with a recently implanted stent. So the question is, what do we do? My opinion, you should always give a loading dose 24 hours after the last maintenance dose to avoid the drug interaction that we saw in SWAP-2 because you're looking at different agents. We're looking at this at the SWAP-4 study, which will be presented at the AHA next year to support this hypothesis. So to kind of summarize, you see in this cartoon, I know there's a lot of data on switching, a lot of confusion. I'll allude to this cartoon, which we recently reported in Nature Reviews, that looks at the switching of oral therapies in acute and chronic phase in every possible salsa. So a lot of information here that in my talk, but you can just look at this cartoon. It's a rapid review. And we also have here some of the future considerations, which is switching from cangalor to the newer therapies. And again, because of the drug interactions, when switching to etinapiridine, give the drug at the end of the infusion. If you're giving ticagrelor, it doesn't matter before, during, or after. Very good marriage between the two drugs. Thank you very much for your attention.
Thank you, Dominick. It's my privilege to invite Professor Dr. Adnan Kastrati, that is Deputy Director in the Deutsches Herzzentrum in Munich. The title of the talk is Duration of Antiplatelet Treatment After Revascularization with PCI or CABG in Acute Coronary Syndromes. arguments for and against longer and shorter duration. Professor Kastrati.
Thank you, Dr. Marín. You can understand now the complexity of my subject after the presentation of Dr. Angiolillo. Dominick was concerned about prolonging antiplatelet therapy by 40 minutes, and I have to speak here about months and years of duration of antiplatelet therapy. In principle, the benefit from a certain type and duration of antiplatelet therapy is determined by the balance between efficacy, reduction in thrombotic events, and safety impact on bleeding. Why we are saying this? Because there are many correlations between myocardial infarction and prognosis and mortality, between bleeding events and mortality. Here I'm showing the results of an analysis from the ESA trials, and you see here that both myocardial infarction seen after the procedure and bleeding seen after the procedure are correlating with mortality over 1 year. If you put all together myocardial infarction, bleeding, and other parameters to a multivariate model, you see that the independent role of both bleeding and myocardial infarction is much higher than any other parameter. And this is irrespective of the type of definition of bleeding. Here you see the model, multivariate model, without putting bleeding in it, the black line, and the colored lines are those after putting also BARC or TIMI or replace bleeding definitions. Now, you have seen that our correlations were always done with all-cause mortality. And it was very interesting, this commentary about 20 years ago from Stefan Gottlieb. He wrote, "Dead is dead, artificial definitions are no substitute." And at the end of his commentary, he wrote that we should seriously question conclusions based on these classifications, death classifications, rather than the objective and clinically useful endpoint of total mortality. Total mortality, all-cause mortality, has also the advantage of no need for complex adjudication processes. Let's look at what is happening with adjudications, central adjudications, for example, of myocardial infarction. Here are 3 different trials, and trial 1, with the need for greater MI reduction by the active drug, by experimental drug. You see here, investigators reported a difference of 72, absolute difference of 72 cases in favor of the active drug. After central adjudication, this number increased to 145, making the result from non-significant to significant. In trial 2, need again for greater MI reduction. The difference in MI reported by investigators was in absolute numbers 44 cases. It increased after central adjudication, they are all blinded studies, to 89 cases, rendering the results from non-significant to highly significant. Let's look at to another trial, trial 3, with a drug which was accused to increase myocardial infarction. Investigators reported a plus 24 cases of myocardial infarction. After central adjudication, it became 8 cases only. So it means that the adjudication is a very complex process that might distort also the results. Total mortality is something that cannot be distorted. This picture here shows also the complexity of getting a good balance between bleeding and between antithrombotic effects. Here is a large series treated with clopidogrel in which we measured platelet function, and you see for all those patients in which there was an enhanced inhibition of platelets, you see a low incidence of thrombotic events, but a high incidence of bleeding events. On the opposite, for those patients who didn't respond well to clopidogrel on the basis of platelet function studies, you see that they had a higher incidence of thrombotic events and a lower incidence of bleeding. So you have to stay to an intermediate range of platelet inhibition to get the best balance between ischemic events and bleeding events. But is increased bleeding a fatality of improved antithrombotic regimen? Let's see a case 20 years ago, the first ISA trial, which replaced anticoagulation with dual antiplatelet therapy. It was a relatively small trial in terms of current clinical trials, 570 patients, randomized between antiplatelet therapy and anticoagulation therapy, all stented patients, and we looked at the 30-day follow-up. You see, through the dual antiplatelet therapy, you get a large reduction of bleeding events. On the same time, you see also a reduction in ischemic events. Let's see a more recent trial, the WOST trial. 573 patients randomized to dual versus triple therapy in patients who need anticoagulation. Here also, changing from a triple to a dual antithrombotic therapy, you get reduced bleeding events, but also reduced ischemic events. That means that not always you have this correlation between increased bleeding and reduced ischemic events. What is the price for bleeding paid for approved effective antithrombotic drugs? Here, the data for aspirin in patients with unstable angina are very old trials. And you see here that aspirin versus placebo in more than 1,000 patients with unstable angina yielded a reduction of death, MI, ischemic events, let's say, of 50% and more. And there was no evidence in blood loss with aspirin. For acute myocardial infarction, here are the data from the ISIS-2 trial, published 88 on Lancet. And aspirin reduced the vascular death by 23%. It was a significant result, and major bleeding was not affected significantly. Let's see what was the experience with heparins in non-ST segment acute coronary syndrome. Here is a pooled analysis from Eichelboom, Lancet 2000. It reduced death MI by more than 40%, and bleeding was increased by 41% in these studies. Clopidogrel in non-ST segment elevation acute coronary syndrome, the results of the CURE trial, cardiovascular death, MI, and stroke were reduced by 20% by clopidogrel versus placebo over 1 year in more than 10,000 patients, and major bleeding was increased by 38%. We have the recent trials with prasugrel and ticagrelor. Prasugrel reduced cardiovascular death, MI, and stroke by 19%, and the increase in bleeding was by 32%. Ticagrelor versus clopidogrel in more than 18,000 patients. Reduction in ischemic events, cardiovascular death, MI, stroke of 16%. Major bleeding was increased by 19%. Overall, we can say that the antithrombotic drugs that have been approved for use so far in acute coronary syndromes have reduced ischemic events by 16 to 51% without increasing the bleeding risk by more than 41%. What are telling us the AAC guidelines on non-ST segment elevation, guidelines of 2011, about the duration of dual antiplatelet therapy? You see here that P2I12 inhibitor should be added to aspirin as soon as possible and maintained over 12 months. Class 1 and level of evidence A. Where is based this recommendation? It is based on the CURE trial, on the Plato trial, and Triton trial. CURE trial, I have shown this curve before, and it showed a reduction in the primary endpoint of cardiovascular death, MI, and stroke of 20%. And if you perform a landmark analysis, the reduction was homogeneous within 30 days and after 30 days. We have to consider also that the mean length of therapy was about 8 months, not fully 1 year. We have the new ADP receptor antagonist, irreversible, a new irreversible like prasugrel, a new reversible like ticagrelor. And you know the results of Triton trial I have shown also before regarding ischemic and bleeding events. Here are both summarized, showing a reduction in ischemic events, but an increase in bleeding events. On the other side, very similar results achieved by ticagrelor in the same patient population, but given before the PCI. You see here also a reduction in ischemic events by ticagrelor. What's about the duration of therapy in non-ST segment elevation acute coronary syndromes patients treated by CABG? Here, the guidelines of 2011 give ticagrelor or clopidogrel a class 2A indication. They should be started as soon as possible after CABG. Where is the evidence for that? This is a subset of patients in the Plateau trial who were treated by CABG. You see here the numbers, more than 1,200 patients who were treated by CABG in the Plateau trial. And you see also that more than 1/3 of the patients didn't start ticagrelor at all after CABG. And the other proportion of patients, they either started within 7 days after CABG, it was the majority of those who restarted the therapy, or very late after 14 days. What were the outcomes in this population? The primary endpoint of the Plateau trial was not significantly different in this subset of patients, but the results were striking regarding mortality reduction or cardiovascular mortality reduction with this therapy, even in CABG patients. And what was more interesting, ticagrelor that increased bleeding in the overall trial didn't increase bleeding in this subset of patients who were treated with CABG. So for STEMI, there are the guidelines of 2012, and they also give a 12-month therapy, DAP therapy for patients with SS segment elevation myocardial infarction. Now, what has happened between 2011 after these guidelines? There have been 11 randomized trials. A few of them were also before the guidelines. 11 randomized clinical trials on the duration of DAP in patients treated with stents, mostly with drug-eluting stents. The proportion of none of these trials was dedicated to acute coronary syndrome patients, but the proportion of patients was as low as 23% in the italic trial and as high as 74% in the trial of Marco Valgimilli. So, although with this proportion maybe they cannot contribute much to the duration of therapy in this specific subset of acute coronary syndrome patients, they were very helpful to generate 25 meta-analyses. I cannot lament here because 2 of these meta-analyses are from my colleagues, so about 8% of this meta-analysis. Here, just to start with one of them, prior to the DAP trial, Cassese pulled together the data from these 4 randomized trials. They had, as you see here, different comparison, 6 versus 12 months, 6 versus 24 months, 12 versus 24 months, and 3 versus 12 months. So the question he put here was, is extended dual antiplatelet therapy beneficial? And here is the answer. Extended therapy didn't impact on mortality. Mortality was unchanged. Extended therapy didn't impact, it was before DAP trial, didn't impact on stent thrombosis, but it increased major bleeding events, as you see here, by a factor of 2.64. Then came the DAP trial, which is the largest trial on this topic, with more than almost 10,000 patients, and the investigators here looked at the value of extended therapy beyond 1 year up to 3 years. You see here that there was also an observational period of 3 months that was related to the concerns that after the discontinuation of therapy, you may get a rebound phenomenon and increase in ischemic events. DAP trial showed a very clear effect of the extension of therapy on stent thrombosis. It was reduced by more than 70% if you stop the analysis at 3 years. If you get further, it was a reduction of more than 50%. But you have also to consider that Taxus contributed a lot in stent thrombosis cases. Although Taxus treated patients who were only 27% of the whole population, they contributed with 57% of the stent thrombosis cases. Bleeding events. You see here that all BARC-defined bleeding events were increased by extending dual antiplatelet therapy. On the other side, related to the reduction of stent thrombosis, you see in the DAP trial a reduction in myocardial infarction rate by extending therapy up to 3 years. Total mortality, at the opposite, was increased, and you see here by a factor of 1.36. So at the time, FDA issued this statement here: healthcare professionals should not change the way they prescribe these drugs at this time. And there was a very quick meta-analysis, the time published on Lancet. The conclusion of the authors was that it is associated, the extension of therapy, it is associated with increased mortality because of the increased risk of non-cardiovascular mortality, not offset by a reduction in cardiac mortality. And this is exactly what I said before, the importance of assessing total mortality when looking at these substances. Now, if we have to summarize the results in a second meta-analysis, after DAPT was published, you see here altogether there are more than 30,000 patients. Extension of therapy reduced stent thrombosis after putting also the DAPT trial in this pooled analysis, increased bleeding by 63%, increased slightly also total mortality, which was not was marginal effect because the significance level was not achieved in this case. So what was the impact of all these trials, except for increasing the number of meta-analyses? You see here, European Heart Journal, 2011, the guidelines on non-ST segment elevation acute coronary syndromes. The recommended time was 12 months. Guidelines of 2015, again, the recommended time is still 12 months. And if you look at the references, they are the same. It means that the task forces didn't change the recommendation, didn't use new evidence for changing that. On the other side, it issued also a statement here that it might be also shorter, 3 to 6 months after DES implantation in patients with a high risk of bleeding. And this statement was based on 3 trials, as you see the references, RESET, Excellent, and ESA-SAFE trial. Now, 2016 came out also guidelines from the task force of the ACC-AHA. Here are the recommendations for patients with stable coronary artery disease. And you see here that the maximal length recommended here is 6 months, 1 month for bemetasense. But even for stable patients, you can go further to 6 months, and this was given a 2B recommendation. That means you may consider prolongation of the dual antiplatelet therapy even in patients with stable coronary artery disease. And here is the recommendation for acute coronary syndromes. It's, again, 12 months recommended. With the guidelines of European Society of Cardiology 2015, you see that there is a possibility to extend the therapy beyond 12 months, and the recommendation gets a class 2B. So you may consider extending therapy beyond 12 months in patients with acute coronary syndromes, which is the same as it was issued by the task force of the American College of Cardiology, American Heart Association. Before 2011, we didn't have this recommendation. Maybe we have done it in our practice in some patients with a lower bleeding risk, with a high ischemic risk. We continue to give dual antiplatelet therapy beyond 12 months, but the reason for giving this recommendation was the publication of the Pegasus trial, a very large trial with more than 20,000 patients, all stable patients, but with a history of myocardial infarctions 1 to 3 years prior to the randomization. But they had to have also one additional ischemic risk, and you see here age or diabetes, etc. They were randomized in 3 groups: ticagrelor, 19 milligram, ticagrelor, 60 milligram, or placebo on top of aspirin. Here are the main results. The primary endpoint here also was cardiovascular death, myocardial infarction, and stroke. And you see a reduction in both doses from 9% to less than 8%. Bleeding was the primary safety endpoint, and you see with both doses an increased risk of bleeding as compared with the placebo group. If you look at the total mortality, you don't see any difference between the 3 groups. Now, it is justified to go deeper and make subgroup analysis to see which was a subgroup that benefits more and or had less disadvantages. And it was done here related to the period or length of the period in which the dual antiplatelet therapy was discontinued before going to be randomized in the Pegasus trial. Some patients, or part of the patients, 7,000 patients, it was a large group, did have this discontinuation within 30 days, so they had stopped, but not longer than 30 days, the dual antiplatelet therapy after the acute event. And the other 2 groups were beyond 30 days or beyond 1 year. And you see here that there was a large reduction in the primary endpoint, ischemic endpoint, cardiovascular death, myocardial infarction, and stroke in those patients who had a shorter discontinuation of therapy before being enrolled in the Pegasus trial. The other groups with a longer discontinuation period, they didn't have a benefit. Even in this group, you see that the bleeding risk was very much increased with a factor of 3.3, 330%. On the other side, mortality was not impacted by this therapy. So I'm showing here only the 60 milligram because this gave also the best result in this trial. To conclude, 1 year dual antiplatelet therapy duration is advisable in the majority of patients with acute coronary syndrome. Longer or shorter duration of DAPT might be considered in certain subgroups of acute coronary syndrome patients, depending on the balance between a risk for ischemic and risk for bleeding events. And it was before, in the session before, was also a question about the risk stratification of these patients, and we are happy to see more and more efforts to develop risk scores in order to help us to find out which subgroups benefit in terms of reduction of ischemic events and which group have the disadvantage of increasing the bleeding events. Thank you very much for your attention.
Now it's time for the last speaker. This is Marco Valgimigli. Now he is Associate Professor in Swiss Cardiovascular Center in Bern and is going to tell us about unresolved issues on concomitant anticoagulation treatment in acute coronary syndrome. Whatever you want, Marco.
Thank you. Thank you very much. Good morning, everybody. I have today actually a very difficult and challenging task, which is twofold. From one side, to speak about, after Dominick and Adnan, the other one is to speak about unresolved issue on concomitant anticoagulation. And actually, I've been asked to discuss both parenteral anticoagulation as well as oral anticoagulation as a long-term secondary prevention treatment strategy. I will try to keep it short, if anything, because I'm the last speaker of the last session. Now, I would like to actually put some fuel on the fire with respect to the debate which has been going on forever with respect to bivalirudin versus unfractionated heparin. And I have updated the evidence that we have so far, and I have stratified the treatment strategy with respect to the type of ECS, because I think that will be most informative for us. So I pulled together all studies available with respect to BIVA versus UFH in primary PCI, with bivalirudin based on current on-label regimen. We have seen many studies in the past with very different regimen. I will not touch base on those. If we restrict on our 6 RCTs where bivalirudin was on-label used, and this drug has been compared to basically any possible combination with UFH alone, UFH plus systematic GPI, or UFH plus some use of GPI, which was either reasonably high in Neuromax or reasonably low in metrics. That's what we have for primary PCI patients, 6 different studies, roughly 14,000 patients included. And if you look into the question about mortality, you do see a signal which I have to emphasize is actually borderline, because the p-value is exactly 0.05, with the upper limit of confidence interval actually touching the equivalence line, suggesting that there is a reduction in mortality favoring bivalirudin. Now, if you look into the fact of the 2 biggest studies ever performed on the topic, Horizon Semi and Matrix, including roughly 3,000 or 4,000 patients, it's quite impressive to see they ended up showing exactly the same things with respect to mortality. In both studies, in the control group, event rate was 3.1%, and then in the experimental group was down to 2.1%, 1% absolute difference, leading to a number needed to treat of 100. Bivalirudin is consistently reducing the bleeding liability, and that's again a very consistent message coming throughout all studies so far performed, with the pooled advantage in terms of highly significant 30% relative risk reduction. But as we all are aware of, there are also trade-offs in the use of bivalirudin, which is largely related to the risk of stent thrombosis. And again, this is a consistent message coming throughout all studies, as well as out of the 2 bigger studies so far performed, Horizon Semi and Matrix. A relatively different number, but if you look at the absolute risk difference, pretty much the same, 0.7, 0.6%. If we flip the coin and if we look into the other side of the equation, namely non-STEMI, things are getting interesting, because actually we do have a signal that the results may differ in non-STEMI. You don't have the signal that we have seen for STEMI with respect to total mortality. Actually, the pooled odds ratio is slightly going in the wrong direction, 11% relative increase, non-significant of course, but still the number are disfavoring bivalirudin for overall mortality. You do have a highly consistent message with respect to bleeding. Actually, all studies so far performed with bivalirudin, irrespective of the comparator arm, are showing a bleeding advantage favoring bivalirudin. And also, unlike what we have seen in STEMI, in non-STEMI, you do not have a clear signal of increased stent thrombosis. It's actually, there is a small trend, 29%, but the trend is not reaching statistical significance, and that most likely has to do with the fact that the vast majority of these studies were based on largely pre-treatment with P2Y12 inhibitor. So to make a long story short, is there a winner? I honestly don't think so, at least not a winner between the 2 antithrombin type. I think the real winner is you, is the clinician, who can today make an informed decision whether to stay with the cheap but very widespread antithrombin type and fractional heparin, which does have limitation we are all aware of, but is actually extremely common in practice and does not cost anything, or the more sophisticated drug, which does provide, I think, a consistent bleeding message, which may or may not translate into the mortality benefit. Now, let me quickly switch to the second part of my talk, which is actually the most challenging one, which is the possibility to add as a long-term secondary prevention treatment strategy an oral anticoagulant compound in our everyday clinical practice. And I think I have to go back in the past to be able to understand how the future may look like. And that's why I started here with WARRIS 2. I don't know how many of you are familiar with this study, but it's 2002, so quite 14 years ago. In the New England Journal of Medicine, over 3,600 post-MI patients recruited in Europe, in Norway actually, in between 94 and 98. And patients were randomly allocated, and I need to emphasize this was a largely medically managed patient population, The proportion of those undergoing revascularization was limited to 5 to 6%, so it was really medically managed patient population that were randomly allocated to receive the standard of care aspirin or warfarin, or the combination of both, warfarin and aspirin. Here you see the landmark, the event-free survival with respect to survival analysis, and you clearly see the winner was actually the combination of both with respect to the ischemic events. Warfarin was anyway in between, and aspirin was clearly not the winner of this head-to-head randomized comparison. Now, the composite was endpoint, the composite primary endpoint was a combination of these three elements: reinfarction, thromboembolic stroke, and death. There was no clear signal for death. Actually, the number was slightly disfavoring the OAC-based treatment strategy, but the benefit with respect to the primary endpoint were actually coming from reinfarction, 50% risk reduction, and thromboembolic stroke, again, 50% treatment reduction. As expected, patient taking OAC, warfarin in this case, had to place a quite considerable price in terms of higher bleeding risk. The same year, different journal, The Lancet, a lower patient population in terms of number, roughly 1,000 patients, with prior ACS within 8 weeks, who have again been randomly allocated to these three treatment strategies: aspirin alone, warfarin alone, actually that was Coumadin, or a combination of both. And again, the winner here was not aspirin, but was again the OAC-based treatment strategy. And this time actually the composite endpoint, which was exactly the same, death, MI, or the risk of thromboembolic stroke, was actually in favor of an OAC-based treatment strategy, largely because of a difference in mortality. There was no signal for MI and no signal for a difference in thromboembolic stroke in this relatively small patient population, as well as no clear difference with respect to the bleeding risk. Now, all this excitement or enthusiasm towards an OAC-based treatment strategy actually got completely blocked down the road for the emerging amount of evidence and data suggesting that after PCI, the treatment strategy to go was really a DAPT treatment strategy. And among the studies that we have here, the most important one was actually here the STARS. And I acknowledge the study coming from Munich, if anything, because the war was the first study. But the beauty of the STAR study is that also the combination of OAC and warfarin was included here. And what you see here, that actually that did not drive much of a difference with respect to stent thrombosis. The huge reduction in stent thrombosis was really driven by the addition of a P2Y12 inhibitor on top of aspirin. And for multiple years, that was the way we have been practicing. And actually, that is still true today. Yet, despite this evidence, we do have, from a mechanistic standpoint, a clear signal that despite antiplatelet therapy, we do have a persistent anti-hypercoagulable state after ACS, so at least a persistent thrombin generation activity down the road, even months after the patient has had an acute event. And that was the rationale for many years ago to put together, now that more reliable oral anticoagulation have become available, the non-vitamin K antagonist agents, put together a dose-finding study. It's Atlas TIMI 46, where 4 doses of rivaroxaban have been tested on top of aspirin and, if needed, aspirin and clopidogrel. Overall, you see a signal for lower ischemic risk in the rivaroxaban-based treatment strategy as compared to aspirin only, but at the same time, of course, as you may expect, you see a dose-effect relationship with respect to the bleeding risk. So based on this quite impressive linear increase in bleeding risk, the investigators selected only the lowest 2 regimens, which were carried forward in the large phase 3 studies, which was actually published in the New England Journal of Medicine quite some years ago. And that's Atlas 2, where rivaroxaban 2.5 BAD or rivaroxaban 5 milligram BAD was compared to placebo. The primary endpoint was the typical CV death MI stroke, and many of you probably are aware of the results, but let me dwell upon the results a bit, because there were some surprises here, at least in my mind there were surprises. The primary endpoint was positive, favoring rivaroxaban, and especially the lower dose of rivaroxaban. The big surprise to me came from the cardiovascular death. Actually, death per se was even more significantly reduced in favor of rivaroxaban as compared to the primary endpoint. And if you look at the all-cause death, that was also going in the same direction. And actually, if anything, the results were even stronger than cardiovascular death. Don't look at the p-value, look at the absolute difference in event here. Look at the 2.7 versus 4.1, look at 4.5 versus 2.9. The absolute difference in the range of 2 point something % with the number needed to treat, which is quite favorable. Now, if you look into the stratum of patients who got already treated with DAPT, so rivaroxaban was actually tested on top of aspirin and clopidogrel, the results were, if anything, sound enough, or at least I should say consistent. And also the second piece of information, the second news that came out of the study, the first one to me at least was cardiovascular death or all-cause death. The second one was, look, even an OAC-based treatment strategy is doing the job with respect to the prevention of stent thrombosis. Not a huge difference. Look at the numbers here. We are not speaking about 1 or 2% absolute difference, but still, in the setting of these large studies, you do see a clear signal that rivaroxaban, even at low doses, can decrease the risk of stent thrombosis. Now, it's also important to emphasize the other side of the coin, as previous speakers have actually dwelling upon before. This ischemic benefit came at a considerable price with respect to bleeding. And actually, if you look at the numbers are quite impressive. 0.6% 2-year Kaplan estimate with respect to TIMI major bleeding complication in aspirin-treated only patients, or aspirin and clopidogrel-treated only patients. And then this risk goes up to 1.8, 3.5-fold higher, or even 2.4, 4.5-fold higher in patients having received rivaroxaban. The good news, or the relatively good news, is coming from the 2.5 regimen, which does not increase fatal bleeding complication and does not increase, at least at a statistical significant level, the risk of intracranial bleeding. But still, these numbers here are quite worrisome. Now, the difficulties in applying this evidence into our everyday clinical practice, I think, is twofold. If you look at the ischemic side of the equation, I think the data provided by Atlas TIMI 51 are quite solid. If anything, if we do a very non-scientific exercise, that's what I'm doing right here, meaning indirectly comparing the absolute and relative risk difference observed in Plato, in Triton, and in Atlas TIMI 51, actually what you see that there is nothing looking bad with respect to rivaroxaban. If you look at the primary endpoint, which was actually pretty consistent across these 3 studies, or perhaps even importantly, if you look at all-cause death or cardiovascular death, actually rivaroxaban looks pretty much favorable. If you look at the relative risk reduction for all-cause death, this is 36% in Atlas, 24% in Plato, not significant, perhaps small benefit in Triton. If you make all analysis with respect to the ischemic benefit, actually Atlas TIMI 51 does not appear bad. What is really limiting the possibility to embrace this new treatment strategy in our everyday clinical practice is really the safety side of the story. There was, of course, a price to pay even in Plato and Triton with respect to the extra ischemic benefit, but this price was actually in the range of 0.6%, leading to a number needed to treat for arm of 167, exactly the same for both studies. If you look at the same endpoint in Atlas, actually that was unfortunately twice higher, with the number needed to treat for arm only of 83. That is the first limiting step to embrace this strategy in our clinical practice. And the second one is the way rivaroxaban has been investigated is a bit counterintuitive. Let me tell you why. We have to take decision with respect to which P2Y12 inhibitor to go for in our everyday clinical practice pretty much upstream. Maybe before taking the patient into the lab, or maybe just in the lab, that's what we have been discussing before, but still, the decision is quite upstream. We cannot wait 1 or 2 weeks to decide which P2Y12 inhibitor to embrace. Whereas the condition, the reasoning of the thinking of adding rivaroxaban is something which, as per study design, has been investigated only at the end of hospitalization, when all revascularization took place already. So here, a patient who could benefit from a stronger and more potent agent have already been selected. And these patients have already been selected for being good prostacyclin or ticagrelor candidate. At this stage, only the clopidogrel-treated patients are probably those who are older with more comorbidity and with the higher bleeding liability. And at that stage, probably the decision to add rivaroxaban, it's already too late. This patient not good rivaroxaban candidate either, and the potential good rivaroxaban candidate have already been treated with Ticagro or Prasuger, where this treatment strategy, rivaroxaban, has never tested on drop-off. I have to admit that 3 is my favorite number. I cannot tell you why. That's always a gut feeling. That 3 is my favorite number. But in cardiology, does not seem to be a good number. When we need to have 3 agents to block one single pathway, things do not turn out fine actually in cardiology, and not specifically only in antithrombotics, also in antithrombotics. Let's go back to the past. We have tested the combination of beta blockers, ACE inhibitor, and angiotensin II receptor antagonist in patients with heart failure. Not greater benefit and perhaps some side effect, so some concern with respect to tolerability. With triple therapy, unfortunately, even more for antithrombotics, we see absolutely the same story. 3 is not a good number. We have to reduce this number. And that's why, to make some room for possible new antithrombotic agents, many of us are currently questioning the way antithrombotics has evolved over time. We have always given the priority to the very old aspirin. Aspirin has always been considered the unavoidable antithrombotic on top of which to keep adding. We have at the beginning added ticlopidine, as we have seen, and then clopidogrel with the cure, and then Prasuger, and then Ticagro. And now we have new oral antiplatelet agent, Vorapaxar, and we keep adding on top of these 2. And when the patient is also in the need for oral anticoagulation for AFib, then we add an oral anticoagulation. This system probably is not a good one. That's what we keep seeing more and more. If anything, because we have reached the ceiling effect of how high we can go with antithrombotics. And that's why it's probably right time to ask ourselves a critical question. Can we get rid of aspirin once at least we can rely on reliable P2Y12 inhibitor? In reality, we do have some answer already in the literature. The most important study is actually coming from our colleagues, from neurologists. They have run this seminal study already some years ago. Patients with prior stroke or TIA. We are speaking about over 7,000 patients. All of them were receiving clopidogrel and randomly allocated to receive aspirin or not on top of clopidogrel. There was nothing to gain with respect to efficacy, and actually there was a huge amount of extra bleeding liability in patients taking a DPT regimen as compared to those only taking clopidogrel, which was in terms of any major bleeding complication, but quite importantly, even in terms of intracranial bleeding. And you see the Kaplan-Meier curves here. Adnan has already shown us the result of the VU study. A relatively small study, but still we have to give the merit to this study of being the first one, at least in interventional cardiology. 573 patients, where a triple antithrombotic regimen has been compared to a double, and the double means they got rid of aspirin, clopidogrel, and the Dominick antagonist. By doing so, the number of any bleeding complication got dramatically down. Number needed to treat for arm 4 to avoid one bleeding event. That's quite impressive. And if you look at the ischemic side of the story, no signal whatsoever that we were losing anything with respect to ischemic efficacy. And if anything, all-cause mortality went in the wrong direction. Starting from 6 months onwards, it started increasing dramatically in the triple therapy group, and actually was pretty much under control in the other group. And that's why, based on this new way of thinking, there is a new wave of studies actually tackling the need for aspirin in everyday clinical practice. The first one, which will probably be presented roughly 2 years down the road from now, is the Global Leader study, where we have focused on a largely unselected patient population undergoing PCI. Patients were on an all-comer basis. They got treated with a guidelines recommended treatment strategy consisting of a DPT for 1 year, followed by aspirin for another year. That's what the guidelines are telling us to do, versus a new treatment combination, 1 month of DPT consisting of aspirin and Ticagro, and then at day 31 aspirin is dropped, and the patient are kept on Ticagro for additional 23 months. Now, we are removing one antithrombotic agent in the hope the patient will bleed less, but actually the primary endpoint has nothing to do with bleeding. The primary endpoint has to do with efficacy, and the primary endpoint is any cause death or new QAVMI, really to test the question whether less is more. Similar study is actually running, even it's a bit behind with respect to the time schedule. It's a twilight, started in United States and now quickly approaching Europe. All patients are treated with a mandatory DPT regimen consisting of aspirin and ticagrelor for 3 months, and then in the experimental group, again, aspirin is dropped. Patients are left on ticagrelor monotherapy as compared to extra 12 months of DPT regimen. The primary point of the study is actually bleeding, not efficacy. But going back to the starting point, to make room for a possible addition of an oral anticoagulation as a long-term treatment strategy, multiple studies are running. I will be only showing 2 of them because are probably the most suitable for the discussion. The first one is Gemini ACS, which, to the best of my knowledge, will be presented in November at the AHA. It's a phase 2/phase 3 studies, 3,000 patients, all patients with a biomarker positive ACS, who are randomly allocated basically to receive or not to receive aspirin, and instead of rivaroxaban, in a stratified manner based on the P2Y12 receptor that the investigator has decided to go for, either clopidogrel or ticagrelor. And once again here, leveraging on what we have seen in the past, the triple therapy is not even tested. Aspirin is dropped, and a P2Y12 inhibitor on top of NOACs is being tested. Similar study concept, the COMPASS study design, patients are more stable down the road, but post-ACS patient population, where an aspirin long-term treatment strategy is compared to a combination of rivaroxaban and aspirin, or rivaroxaban alone at a slightly higher regimen. So in conclusion, I have 2 statements because I had 2 parts of my talks. The first one referred to parenteral anticoagulation. Bivalirudin does reduce bleeding across the board. I think it's difficult to question that treatment effect today, which may or may not translate into a mortality benefit, especially in STEMI. Bivalirudin is also associated to an excess of stent thrombosis in STEMI, but not in non-STEMI. And I think the clinician can now safely and comfortably choose between which regimen to go for. In the current DPT-based post-stenting treatment strategy era, that's what I would call it, what we are living right now, there is, I think at least, hardly room for an additional antithrombotic therapy, including NOAC at low dose. Therefore, only the result of the ongoing studies may prove the lack of efficacy of aspirin with that respect. If these studies will be successful with that regard, I think we will see a lot of new studies trying to understand the value of a long-term OAC-based treatment strategy, even in patients without formal anticoagulation indications, such as those with AFib. And I thank you very much for your attention.
Thank you, Marco. Excellent talk. The session is open for discussion.
Yeah, thank you very much. My question is actually a pretty simple one. It's addressed to you, Marco. I agree very much with your thoughts about the fact that we may be relying too much on aspirin. And I think, I've tried to make this point a number of times before that, the one thing we can guarantee about aspirin is it may well lead to bleeding. And so I'm just curious, with these trials, all of them seem to start off with aspirin for the first month, and then it's dropped. What do you think about maybe sort of the lack of courage of stopping the aspirin right from the beginning, from day one, recognizing that most bleeding occurs in the first 7 to 30 days, and so the impact would actually be felt in that first 30 days. So I'm just a little disappointed that none of these trials seem to have an arm where aspirin was not given maybe after the MI or PCI, as long as the patient is receiving a potent P2Y12 inhibitor.
Thank you very much, Malcolm, for this great point. I can tell you that when we designed the Global Leader study, there was probably, if I recall it well, 1 week discussion about this point, whether to drop aspirin at the beginning already or at 30 days only. And actually I was among those pushing for at least 30-day DPT to be on the safe side. Now, retrospectively, probably I've done it wrong, but at least I can say that after having recruited 16,000 patients, the Global Leader, and with a very rigorous DSMB activity looking after the safety and having the study not been stopped so far, I think we can already say that at least the safety with respect to dropping aspirin at 31 days, it's quite there. Now, based on this information, which we, of course, didn't have at the time we designed the Global Leaders, I was trying to convince some critical, let's say, antithrombotic manufacturing company to be vague enough to go in that direction, to drop aspirin, at least in the HBR patient population, in patients who are at high bleeding risk already after PCI, knowing that, of course, aspirin will be still there for 5 to 7 days and then will be wearing off. Unfortunately, there seems to be a sort of a lukewarm appreciation from these major companies with respect to the idea of dropping aspirin. They have not invested in this scenario, and I think they've done it very, very wrongly, because I think this the future of antithrombotics is really there to me. But I would be caution having expressing my enthusiasm towards this new concept. I would really caution clinicians to start dropping aspirin. I would say first we need to look into the result of randomized control studies. If the safety and efficacy is going in the good direction, we should not forget that aspirin has been there for more than 100 years. And so I think we should go there step by step, not making too quick jump into the future. But having said that, I think the future is dropping aspirin as early as possible, especially in patients at high bleeding risk.
And Malcolm, I just want to add to what Marco was saying, since I'm deeply involved with the Twilight trial design. We had a lot of discussions as well, but many times the internal discussions can only go so far, because then we have the so-called FDA. So the FDA did not even want to consider anything less than 3 months, particularly considering that Twilight, most patients, for example, were acute coronary syndromes. We were able to get away with 3 months, and one of the biggest problems that we're having with Twilight, and we are behind, that is correct, is that many centers, many of the IRBs just don't feel comfortable with stopping aspirin so soon. So again, it's another challenge. I mean, we would have loved to have that additional arm. We'd also love to have a lot more money to add that additional arm, but we don't have the money and we don't have approval from the FDA, so we move forward with what we have.
Yeah, well, that is a question in the same direction. Probably I still have a lot of doubts on when to use. I mean, when we are using the new antiplatelets, well, they are not already new, prasugrel, anticoagulant, or outside of the acute coronary symptoms. I mean, we all, at least in the clinical practice, when we have a complex PCI, when we have a patient that has not been pre-treated, as you said, Dominick, that you don't do it very often, we always think that we need a more potent and more faster antiplatelet agent, irregardless of the acute coronary syndrome, a stable or not a stable situation. So the question is, are you using that in your regular practice? Although there is no any evidence, what do you think about that? Do we have any subgroup analysis? There is any way to defend us for using these agents in stable patients?
So the short answer is yes, we are. Also because, we're not pre-treating a lot of our patients. We do complex procedures. Yes, there's no data, but yes, we use them in our patients, our stable patients. For example, the ad hoc PCI, these were troponin negatives. There's a very nice data coming from Dr. Neumann's group with prasugrel. I think it's very reasonable, particularly in that first month. And we're actually allowing it in Twilight as well, so that not also that it's a great thing. And I think the beauty is then you can say, let's minimize the risk of bleeding by dropping aspirin. You're covering the highest thrombotic risk period, and which is the first few months. So I do it in my practice. I don't publicize it because it's off-label, but I do it.
Any other question?
My question is for Dr. Angiolillo. You recommend a loading dose to switch from clopidogrel to new antiplatelet, but do you have any data about the bleeding complications at the follow-up in this scenario?
So the short answer is we have registry data that do not indicate any safety concerns. But there are limitations with registry data, and there will never be any larger registry or randomized study to look into it. Personally, looking at platelet biology and the way these drugs work, I don't have any concerns whatsoever. We did a study, I didn't present it for sake of time, which is called Triplet. And these were patients who may have gotten a 600 milligram loading dose 30 minutes prior, or 1 hour prior, just really close, and got the loading dose of prasugrel on top of it. And it was a relatively large pharmacodynamic study, and there weren't any concerns. Now, does this mean in a larger study we would not find any differences? I don't know. But keep in mind that, as I showed, you don't have a problem with overdosing, and you cannot block more receptors than those that you already have.
Okay. Any question more? Dominick, in Spain we have an important percentage of patients that we use fibrinolytic therapy in ST elevation. Any comments about the use of prasugrel or ticagrelor in these patients?
Class 3. Do not do it. I mean, the small amount of data that we have, actually coming from our colleagues in Munich, show that there is an increase in platelet reactivity, increase in bleeding complications. It's interesting because the reason why the study was done is that they tested patients. They were shown to be poor responders to clopidogrel, then switched to prasugrel. And these patients had a threefold increase in bleeding. So the short answer is no. We'll learn more from the trials that are ongoing with the NOACs and dropping aspirin and considering the newer agents. But as of now, the European consensus document says no. The North American consensus document says no. There's going to be an updated consensus document that will probably say no.
Regarding in the revascularization guidelines, also recommends use prasugrel after CABG. Any comment on evidence about the use of prasugrel in this type of patients?
You mean for acute coronary syndrome patients or for acute coronary syndrome patients? So the experience with prasugrel in patients who get CABG is very limited because the number of patients in the Triton trial who were sent to surgery was very, very limited. So I think that for the moment, the best data for this are for ticagrelor because it's the largest subset, although a subset still.
Any comments?
Do I think the same? I always agree with Dr. Kastrati.
Any question more? Okay, sorry. We should close the session. We should remember that we will be able to see the slides very, very soon in the web page or the section. Please visit us.
Yes. And thank you, all you three, for your splendid presentation, and also thank you all of you for being with us until the last minute. We want to record you that the meeting is now over, but we hope see you again in Santiago in 2 years. Please, come with us. You are going to enjoy it if you enjoy this meeting, okay? Come with us.